Hello everyone. So today we have our esteemed guest Dr. Gaurav Kansara. He is an associate professor in the Department of Biochemistry at GMERS Medical College, Navsari, Gujarat. Dr. Kansara holds both an MD and a DNB in biochemistry, and he brings with him a wealth of academic and clinical experience. He has previously served as an associate professor at HBT Medical College and Dr. R.N. Cooper Hospital in Mumbai, and we are honored to have him with us today and look forward to gaining insights from his expertise. Thank you. My apologies, he was an assistant professor at Cooper Hospital.
Thank you, Aman, and good evening to dear students. I was supposed to take this class last week, but because I've had ill health at the very last moment, I could not take the class. So uh, now I was told that I could help students with uh, revision of biochemistry. Now, as such, biochemistry is a whole topic. Revision it could become very cumbersome. If I just keep talking about the different cycles and the different metabolisms. So I decided that I would rather talk about case studies, because case studies ultimately it goes back to revision. It goes back to the metabolism only, because most case studies are based on metabolisms. Recently, NMC has said that even MCQs have to be based on case studies. And already, as you know, that case studies form an important part of the theory examination, where you get cases and then you have to answer the different questions. So that is like instead of writing big question, instead of writing big answers, you can make marks even with very short sentences, provided that you give the examiner the right answer. You can get full marks also in case studies. So case studies are very important for us to understand. Also, case studies are also there in the exam, in the practical examinations also. And even now, even MCQs have to some MCQs have to be based on case studies now. So case studies as such have a very important component of the uh, our examination. And so I decided that I'll talk about case studies, and I'll take case studies one by one. I have a unique method of taking case studies where I have a book where from which I can share the case study main body with you, and then I can discuss the most commonly asked questions and answers. Okay, so at the end of this session, I would also like to have a feedback from you people, that whether my speed is okay, whether my content is relevant, and also you can tell me about whether I need to add some more things or I need to minus some things. Okay, so because I was just so to start with, I'll start with case studies now. Okay, so I am going to project, not actually exactly project, but I'm going to uh, show you a book text from the book which I have. So this is a case study. We'll start with case studies on carbohydrate metabolism. Okay, so there's a case study over here with a 30-year-old female coming to the OPD with chief complaints of diarrhea, flatulence, and abdominal cramps for 15 days. On dietary history, this she revealed that she's been taking milk twice a day, and all other findings are normal. Now, to this case study, also one thing which may be added is that a sentence may be added saying that the symptoms subside when the person stops taking milk products in his diet. Okay, so one thing is he's an adult person, above 18 years of age, and one more hint which you get, which is very clear, is that the symptoms stop when a person stops taking milk products in the diet. Okay, so you can tell me what case this is of? Can anyone tell me what this is a case of?
Lactose intolerance?
Right, right. So this is a case of lactose intolerance. As the main hint over here is the complaints of diarrhea, flatulence, and abdominal cramps. Okay, as an adult person coming with the complaints, and so whenever you come across any case study, important thing you have to see is that what is the age group of the person. A person is a child. If it's a child who is coming with the complaints, there is more likely to be an inborn error of metabolism. But here we have an adult, so that's significant. And the symptoms are diarrhea, flatulence, abdominal cramps. Now, what happens in lactose intolerance is that when the person takes milk and milk products which contain lactose, this lactose has to be broken down in the intestine by an enzyme called as lactase. Okay, lactase breaks down lactose. That's how it is. So when the lactose is broken down, it is converted to glucose and galactose, which are easily absorbed. But if the lactose is not broken down, it will not be absorbed. And the thing is that the bacteria will act on the lactose in the intestine. It will, from the small intestine, it goes into the large intestine where there are bacteria. The bacteria act on the lactose, they utilize it for their needs, and they produce different gases, and they produce different substances, because of which the person gets a lot of gas. Okay? So the symptoms here are flatulence, in which means that the person is passing gas. Okay. So because of the gas production from the lactose by the bacteria, this leads to okay. There's something called as your free meeting will end in 10 minutes.
We will restart the meeting with a new link, sir. After that.
Okay. Okay, fine. So the different questions may come. Some case studies may mention directly that this is a lactose intolerance case, but mostly you will be asked to diagnose from your end. Now, what do you think is the disorder over here? So in this case, this is a case of lactose intolerance. Okay, and the key factors which are in the which is there is the person is taking milk products. Okay, and the one more hint may be given that the symptoms stop when patient stops taking milk products in diet. That is a like clear indication. This is only a case of lactose intolerance. Then the second question which may come is, what are the clinical manifestations and what is the underlying biochemical basis? So clinical manifestation, as you can see, they are given the questions. Okay, diarrhea, flatulence, abdominal cramps. But the reason for the manifestations is that the question may come is, what is the biochemical basis of these manifestations? So when the lactose is not absorbed in the intestine, it goes into the large intestine. The bacteria ferment it, they produce different products which are also osmotically active, and they attract water into the intestine. So this gas and the water is attracted in the intestine. They lead to flatulence. They lead to loose motions. Okay, that is the basis of symptoms. Okay, and as you can see over here, fermentation can produce gases like carbon dioxide, hydrogen, and methane. This may be present in the uh, large intestine. So investigations are required for diagnosis and prognosis. So one investigation is a positive Benedict's test in stools. Okay, if the stool Benedict test is done, it will be positive because the lactose which is there, it's a reducing sugar. It gives a positive Benedict's test. Also, what is important is that the person's breath will contain hydrogen. Okay, so some books it is given that there is a breath hydrogen test, because hydrogen can come in breath only in when if there is production in the body from the bacteria. Okay, so this hydrogen will be present in breath in case of lactose intolerance. Now, how do you treat the patient? So obviously, because the patient is having symptoms because of milk and milk products, you have to ask the patient to stop consuming milk and milk products. But the books mention also that the yogurt or dahi. Okay, so yogurt contains lactobacilli, which break down lactose. Okay, so because of that, the yogurt contains less lactose, and the person can take dahi, even though person cannot take milk and milk products. The person can take dahi. Okay, so this is the basis of treatment to avoid lactose rich food, which are basically milk and milk products, and the person can take yogurt, which is helpful in this case. Okay, so this is a case of lactose intolerance. So now we have a case of hereditary fructose intolerance over here. Okay, again this is visible.
Yes, sir, it's visible.
Visible? Okay. So the case study over which is over here is that again it's a 10-month-old baby. Okay, here we are talking here the case study is mentioning a child. Okay, a 10-month-old baby admitted to the pediatric ward with episodes of vomiting, diarrhea, abdominal distress. The mother is giving history that the symptoms have started. The baby was completely normal before, from birth to 6 months of age, but at 6 months of age, weaning was started. Weaning means that stopping mother's milk and giving some other diet. So feeding of fruit juices and fruits was started. Okay. So over here, the biochemical parameters on laboratory investigations are: plasma glucose is 50 mg per dl. Okay, means the plasma glucose is on the lower side. The child is having hypoglycemia. Urine bending stress is positive. Urine Selevinov test is positive. Okay, so this is the case history. What more may be added is that cataract was observed on uh, this on examination. The child a cataract and hepatomegaly were observed. Okay, so on palpation you may observe hepatomegaly, and on examination of the child's eyes, cataract may also be seen. So this is I'm adding this point from my side, which means that this is a case of what is called as hereditary fructose intolerance. Okay. Now there are two disorders. एक है galactosemia, other is hereditary fructose intolerance. Now in both these cases, symptoms are very similar. Okay, there is a vomiting, diarrhea, abdominal distress that is there, but more important than this, that you are seeing hypoglycemia. Okay. Also, there may be presence of cataract and presence of hepatomegaly. Okay, swelling of the liver. So these patients may be either galactosemia or hereditary fructose intolerance. Now, how do we differentiate between the two? I'll tell you now. Okay. So here, this is a case of hereditary fructose intolerance. The diagnosis may either be given to you directly or you may be asked to diagnose the case. Okay, so inheritance pattern, this is autosomal recessive disorder because here there is a deficiency of an enzyme called as aldolase B. Okay, one aldolase you already know, which is there in glycolysis. Okay, so fructose 1,6 bisphosphatase is broken down by aldolase A to give you glyceraldehyde 3-phosphate and dihydroxyestone phosphate. So यहाँ पे we have aldolase B, okay, which is specific for metabolism of fructose. Okay, so this is there, and because of deficiency of aldolase B, the fructose 1-phosphate is not metabolized. Okay, if you see over here, this is how fructose is metabolized in the body. ठीक है, फिर उसका मेटाबॉलिज्म ऐसे होता है. फ्रुक्टोज से जैसे अपने पास हेक्सोकाइनेज है, वैसे देयर इज एन एंजाइम कॉल्ड फ्रुक्टोकाइनेज कन्वर्ट्स फ्रुक्टोज टू फ्रुक्टोज 1-phosphate. एंड जैसे फ्रुक्टोज 1,6 बिसफॉस्फेट है, इट इज एक्टेड अपॉन बाय अल्डोलेज ए, जो आपका एल्डोलेज है इन द ग्लाइकोलिसिस. सो दिस इज एक्टेड अपॉन बाय एल्डोलेज बी, जहां पे वी हैव फॉर्मेशन ऑफ ग्लिसरॉल्डिहाइड एंड डाइहाइड्रोक्सीएस्टोन फॉस्फेट. इंस्टेड ऑफ ग्लिसरॉल्डिहाइड 3-phosphate, बिकॉज यहाँ पे एक ही फॉस्फेट ग्रुप है. हेंस जो एक फॉस्फेट ग्रुप है, दिस गोज टू dihydroxyestone phosphate and glyceraldehyde. So these two products are formed, and these products further enter into ग्लाइकोलिटिक पाथवे. ठीक है, तो फ्रुक्टोज का जो मेटाबॉलिज्म है ऐसे होता है. अगर ये एंजाइम एल्डोलेज बी नहीं है, what will happen is that this fructose 1-phosphate will accumulate in the body. This fructose, because of accumulation of this will sequester the phosphate. ठीक है, फ्रुक्टोज से फ्रुक्टोज फॉस्फेट बन रहा है, तो उसका आगे मेटाबॉलिज्म नहीं हो रहा है. Fructose phosphate will build up in the liver, and this it will sequester the phosphate, जिसके वजह से एटीपी प्रोडक्शन बंद हो जाएगा. ओके, तो जो आगे जाके उससे क्या होगा कि ग्लाइकोल जो ये होगा, ग्लाइकोलाइसिस बढ़ेगा और ग्लूकोज का लेवल ड्रॉप हो जाएगा. दिस इज द बेसिस फॉर द हाइपोग्लाइसीमिया सीन इन दिस केस. Okay, so at the same time what we say is that because of buildup of fructose 1-phosphate, the liver gets enlarged because of, क्योंकि बॉडी के अंदर फ्रुक्टोज 1-phosphate, जो लिवर के अंदर फ्रुक्टोज 1-phosphate एक्यूमुलेट हो रहा है हिपैटोमेगैली. ओके, तो इसमें आगे यू मे ऑल्सो सी कैटरैक्ट, बिकॉज जो यहाँ पे दिया नहीं है, बट आई एम टेलिंग यू दिस बिकॉज दिस फ्रुक्टोज, बिकॉज ऑफ एक्सेस लेवल ऑफ फ्रुक्टोज, द दिस एन एंजाइम इन द बॉडी कॉल्ड एज अल्डोज रिडक्टेज which converts fructose into sorbitol. Okay, और जब sorbitol जब लेंस ऑफ आई में जब accumulate होता है, that leads to cataract because it attracts water into the lens tissue. Okay, so that also can occur in the later on stages. Okay, so important part over what we see over here is the plasma glucose level is low.
Misunderstanding in term Litron stages. The search results indicate that
Sorry.
Litron is a... Hi.
So this because of the deficiency of this enzyme, and because most enzyme disorders they are autosomal recessive. Okay, आपके मैक्सिमम जो एंजाइम डिसऑर्डर्स हैं ऑटोसोमल रिसेसिव होते हैं, सिर्फ कुछ कुछ ऐसे हैं जो एक्स लिंक रिसेसिव होते हैं. ओके, there is accumulation of glycogen in liver and associated hypoglycemia हो रहा है इसके अंदर. Okay, because fructose 1 phosphate is inhibiting the glycogen phosphorylase enzyme. Okay, तो अभी यहाँ पे why this is only fructose intolerance, क्योंकि यहाँ पे at 6 months of age तक कोई प्रॉब्लम नहीं था, और जब बच्चे के डाइट में फ्रुक्टोज, जब सुक्रोज ने एंटर किया है, उसके बाद सिम्टम्स शुरू हुए हैं. ओके, सो दिस मीन्स दिस इज अ केस ऑफ फ्रुक्टोज इंटॉलरेंस. Okay, so treatment of this patient basically you have to limit the glucose in his fructose in his diet. Fructose का main source is sucrose. Sucrose has to be limited. Okay, so now we have already discussed the case of fructose intolerance. So now we come to a case of what is the galactosemia. Okay, so in a case study which we see again here, now this is a newborn infant. Okay, a newborn infant brought to the hospital with complaints of jaundice and vomiting. The weight is less than normal, liver is enlarged. Again, what we see over here is that there is a positive test for reducing sugar in urine. Okay, additional information which may be given is that you may also be given some additional information like the serum glucose level is low, very similar to what was seen in the previous case. Okay, and here the bilirubin level is high. Okay, so now this is a case of galactosemia. Now, how it is different from the hereditary fructose intolerance is that here we have a newborn infant. Okay, because in a newborn infant में क्या होता है, because as soon as the child is born, the child is given milk. Okay, and when the milk is broken down, it gives you galactose. Okay, and then galactose from lactose you get galactose. Galactose is absorbed, and if the galactose is not metabolized properly, immediately there will be symptoms. If galactose is not metabolized properly, immediately there are symptoms. Okay, so what is now here in this case study the diagnosis is given, galactosemia is suspected. Okay, but many times you may also be asked that what is the diagnosis in this case. Okay, so galactosemia is an inborn error of metabolism. Over here the deficient enzyme is the enzyme called as galactose 1 phosphate uridyl transferase. Now is the uh, okay, so here we actually have the pathway which is catabolized by this enzyme. Okay, we see again galactose, like in the earlier case we had fructokinase. So here for galactose we have an enzyme called as galactokinase. Does the same thing, converts galactose to galactose 1 phosphate. Now this enzyme called as galactose 1 phosphate uridyl transferase. Okay, what it does is that it's a uridyl transferase. Okay, so here we have UDP glucose, here uridine diphosphate glucose. So it is shifting both the groups. Okay, so glucose is being liberated and its place is taken by galactose. So this becomes, so UDP glucose becomes UDP galactose, and galactose 1 phosphate is taken, and glucose 1 phosphate is released. So over here you get UDP galactose, and the UDP galactose epimerase enzyme, as we know galactose is an epimer of glucose. UDP galactose is converted to UDP glucose, which can again be utilized by the body. Okay, in this way this whole pathway is metabolized, and this way जो galactose है, it is metabolized by the body in the early years. Okay, now for the first 4 years of the life, only this pathway is active. Later on, one more pathway becomes active. Okay, but for first 4 years of life, only this pathway is active. So if this enzyme is absent, then this reaction will not take place, and then the galactose 1 phosphate will accumulate in the body. Like in the earlier case study, we saw that if glucose 1 phosphate accumulates in the body, when the fructose 1 phosphate accumulates in the body, it inhibits glycogenolysis, it inhibits breakdown of glycogen, and then there is hypoglycemia. So over here also there will be hypoglycemia. The deficient enzyme is galactose 1 phosphate transferase. The galactose 1 phosphate will accumulate in the liver and it will lead to hepatomegaly. Okay. So this leads to inhibits galactokinase as well as glycogen phosphorylase, leading to accumulation of galactose and hypoglycemia. So because this galactose intolerance and galactose is a part of milk, so symptoms develop very early on in life. Symptoms develop very early on in life. So symptoms are developing in the first few days of life. Okay. Additionally, what happens is that when galactose, just like fructose is converted to sorbitol, Galactose also is converted to dulcitol or galactitol. Okay, this dulcitol or galactitol is the alcohol of galactose. And this galactose, when this dulcitol accumulates in the lens, this attracts water into the lens because it is osmotically active, and this leads to opacification of the lens, also called as cataract. Okay, so because of the accumulation of dulcitol in the lens, there is cataract. Okay, again, there is because of the affection of the liver, there is jaundice and there is hepatomegaly. Okay, again, there is fasting hypoglycemia also. Okay, so we watch what we see in this case is that it is very similar to hereditary fructose intolerance, but in galactosemia, symptoms will start in a very young child, okay, in a newborn child, whereas uh, in fructose intolerance, symptoms start at 6 months of age because it is at that time when fructose in the form of sucrose enters into the diet. Okay, this is there. So how do you diagnose this case? Again, you get a Bendix test in urine because this galactose is present in the urine. Okay. How do you treat this patient? Basically, because this child cannot metabolize lactose, lactose से जो है body में बन रहा है galactose. So to avoid galactose in the diet, you have to avoid all milk and milk containing products. Okay. And one important thing is that after child becomes 5, यहाँ पे दिया नहीं है, but when the child after child becomes 5 years of age, there is a different enzyme which becomes active. It is called as pyrophosphorylase. Okay, and that will break down galactose 1 phosphate. Okay, so that because of that, what will happen is that ये galactose 1 phosphate accumulate नहीं करेगा after 5 years of age. So after 5 years of age, the child can take lactose products in diet. Okay, this is there. So with this we have completed these cases. Now we come to the case of von Guericke disease. Okay, von Guericke disease जो है अभी now we are coming to metabolism of glycogen. Okay. Here we have a 6-year-old child brought to hospital in unconscious state with deep and labored breathing. Again, we are seeing hepatomegaly in this case, and examination of urine sample is showing the presence of ketone bodies. And here we are seeing laboratory investigations are showing glucose concentration of 50 mg per dl. As you know, okay, जो fasting है that is 70 to 110 mg per dl glucose, but here the lab investigation is showing glucose concentration of only 50 mg per dl. Okay, so this is one case of von Guericke disease. How do we see von Guericke disease? Okay. Now this disorder is because of a deficiency of an enzyme called as glucose 6 phosphatase. Now when you study the pathway of glycogen metabolism, okay, how glycogen is broken down in the body. When glycogen is broken down, ultimately the person gets glucose 6 phosphate. A glucose 6 phosphate, when it is broken down further by enzyme called as glucose 6 phosphatase, then the person gets glucose. Okay, and then the glucose can be utilized for different purposes. That is the basis of the reason why the body breaks down glycogen so that we can get glucose. Okay, अभी यहाँ पे ये एंजाइम का डेफिशिएंसी होने की वजह से ग्लाइकोजन इज broken down but ग्लूकोज नहीं बन रहा है. Okay, because तो the pathway is stopping at glucose 6 phosphatase. तो वहां से जो है again because of the accumulation of the product, it leads to inhibition of the pathway, and this way the substrate keeps accumulating. Okay, so von Guericke disease, like the case of most enzyme disorders, it is an autosomal inheritance pattern. Okay, you can remember for most enzyme disorders, the inheritance pathway mostly is autosomal recessive. Okay, so then the biochemical basis यहाँ पे क्या है? Because glucose 6 phosphate. Okay, okay, biochemical biochemical basis क्या है? Because glucose 6 phosphate is not broken down to glucose because of deficiency of the enzyme called glucose 6 phosphatase. This leads to hypoglycemia. कि जो glucose का production है, that is suffering. Okay, so what we see over here is there is fasting hypoglycemia. It is not stimulating to production by stimulation by adrenaline. Okay, so what happens now? The glucose 6 phosphate accumulates now. because it is not broken down to glucose. So now this glucose 6 phosphate starts entering into the alternate pathways. Okay, when you study metabolism of carbohydrates, you will realize that glucose 6 phosphate also takes part in the HMP pathway, HMP shunt pathway. Okay, so excess also in glycolysis pathway. There is for production of excess acetyl CoA. Okay, and what is not written over here is that this HMP shunt pathway also provides NADPH. Okay, because of this, there's a lot because of excess acetyl CoA and excess NADPH, there's production of a lot of cholesterol. Because of this, cholesterol level rises and fatty acid synthesis also increases because there is more production of acetyl CoA, which can lead to synthesis of fats. Okay. Lactic acidosis happens because there is glucose phosphatase deficiency leads to impaired gluconeogenesis. Okay. Then there is acidemia. There is now interesting thing over here. There is hyperuricemia. Okay. One thing which we have not seen in the case study is that uric acid concentration is increased compared to the normal range. Uric acid level is high. Now, uric acid directly is not related to the metabolism of carbohydrates. But what happens in this case is that this extra glucose 6 phosphate which is accumulating is channeled into the alternative pathway, which is HMP shunt pathway. Now, HMP shunt pathway produces ribose. Okay, so it produces pentose, which helps you in the synthesis of the DNA and RNA, ribonucleic acid. So there is production of more pure nucleotides. Excess nucleotides are broken down to give uric acid, which then leads to hyperuricemia. Okay, and the lactic acid which is accumulating also competes with uric acid, and this also leads to hyperuricemia. Okay, and because glycogen breakdown is not proper, this glycogen will get deposited in the liver later on, and this because of deposition of glycogen in the liver, there is massive liver enlargement. Okay, so all the biochemical basis of all the symptoms are available over here. Okay, because this is a genetic disorder, treatment then becomes accordingly. Okay, so investigations which are helping in the diagnosis of this condition is this plasma glucose, lipid profile, lipid profile, and ABG analysis. If there is acidosis, lactic acidosis, then there will be ABG analysis will show you lactic acidosis also in the form of metabolic acidosis. Okay, so this is about von Guericke disease, which is a uh, inborn error of metabolism, a genetic disorder. Okay. Now we come to a important disorder, which is the G6PD deficiency. This is very likely to come in examinations because this is very commonly seen. Okay, G6PD deficiency is the most common genetic disorder. It's the most common genetic enzyme deficiency which is seen in practice. Okay. Okay, तो इसका भी जो case study है, this will be very peculiar, and when you read it, you should be easily able to make the diagnosis. Okay, so here what we are seeing over here is that a 30-year-old male suffering from malaria is put on the drug called as primaquine. Okay, and during treatment, the person is developing signs of anemia, just pallor, fatigue, and breathlessness. Also giving history of passes of dark colored urine. Okay, and the laboratory test is showing the reduced level of hemoglobin, which means that there is anemia, there is raised levels of bilirubin, and liver enzymes are mild rise. There is not much rise in the liver enzymes, but bilirubin level is raised. And in some cases, you may also be given a further hint. Total bilirubin level is high, and the indirect bilirubin level is high, but direct bilirubin level is not high. Unconjugated bilirubin का level ज़्यादा है इस case में, which would point to a hemolytic anemia. Okay, when you are given the case of bilirubin, you should try to find out कि जो bilirubin अगर बड़ा है तो उसमें conjugated bilirubin बड़ा है, unconjugated बड़ा है. Okay, so this will be extra will be given to you. Unconjugated bilirubin level is higher, and liver enzymes में ज़्यादा कोई रेज नहीं हुआ है. Okay, liver is predominantly normal. तो यहाँ पे important point यहाँ पे है कि यहाँ primaquine दिया हुआ है इस patient को. The primaquine, this drug is only given to a person in which there is no deficiency of glucose 6 phosphate dehydrogenase. पहले वो टेस्ट करना पड़ता है. अगर टेस्ट नहीं किया है, ये ड्रग दे दिया है, this drug can lead to hemolytic anemia. Okay, so diagnosis over here is hemolytic anemia, the jaundice because of deficiency of the enzyme glucose 6 phosphate dehydrogenase. ये enzyme deficient होने के वजह से क्या हो रहा है? This enzyme is a part of the HMP shunt pathway. Okay, so when this enzyme is deficient in the HMP shunt pathway, what happens is that because this enzyme is deficient and you are giving primaquine to this patient, the primaquine leads to if you read it further, you see that primaquine when it is given to a patient with a GCP deficiency, there is a large production of free radicals in the RBC of this patient, and unless the free radicals are neutralized, if they are not neutralized, they will damage the RBC membrane and they will lead to lysis of RBC membrane, lead to hemolysis. Okay, so we can see over here, okay, there is hemolytic anemia. Okay, why is there dark colored urine? Okay, dark colored urine is there because of the hemolysis. Okay, and what we see over here is that there is reduced blood hemoglobin level because of hemolysis, जहाँ पे RBC because of the hemolysis there is hemolytic anemia. Raised bilirubin is because of the rise in the indirect bilirubin, क्योंकि जो hemolysis होने के बाद जो सेल्स में आरबीसी में से हीमोग्लोबिन निकलता है, उसका जो हीम पार्ट है दैट इज कन्वर्टेड टू बिलिरुबिन, दैट लीड्स टू hemolytic, that leads to rising bilirubin levels. अभी जितने भी आपके अलग अलग जो एंजाइम डेफिशिएंसीज हैं, दे आर मोस्टली ऑटोसोमल रिसेसिव, बट देयर आर सम एक्सेप्शंस. उसमें इंपॉर्टेंट एक्सेप्शन यहाँ पे है that G6PD deficiency is X-linked recessive and it mainly affects males. तो ये जो है इंपॉर्टेंट बात है कि ये जो है X-linked recessive है और मेल्स को अफेक्ट करता है. ओके, तो यहाँ पे we can see that this is a reaction where glucose 6 phosphate is converted to 6 phosphogluconate or gluconolactone basically. तो ये जो है this is the first reaction of the HMP shunt pathway, जहाँ पे glucose 6 phosphate dehydrogenase enzyme जो है एक्टिव होता है. इफ दिस एंजाइम इज डेफिशिएंट तो फिर NADP से NADPH का जो प्रोडक्शन है कम हो जाएगा. ओके, सो NADPH का प्रोडक्शन जो है आरबीसी के अंदर दिस विल बी लेस एंड NADPH इज रिक्वायर्ड टू कन्वर्ट ऑक्सीडाइज्ड ग्लूटाथायोन टू रेड्यूस्ड ग्लूटाथायोन. ओके, तो अगर NADPH का लेवल कम है तो जो फ्री रेडिकल्स है आरबीसी के अंदर वो उतने इजीली ब्रेक डाउन नहीं होंगे and they will accumulate and they will damage the RBC cell membrane because of deficiency of this enzyme. Okay, तो कहीं पे पूछे sometimes this question is asked कि उसका फायदा क्या है. Okay, now this when NADPH is present, so the glutathione reductase enzyme can easily convert the oxidized glutathione to reduced glutathione, which helps in the breaking down the peroxide which is a free radical. Okay, उसका break down के लिए the body requires reduced glutathione which comes from glutathione reductase which requires NADPH. Okay, so this question is sometimes asked what is the benefit of this mutation to the person. So because even the RBC, because RBC का लाइफ स्पैन कम हो जाता है इस डिसऑर्डर के अंदर, तो जो मलेरिया पैरासाइट है उसकी जो लाइफ साइकिल है दैट बिकम्स हैम्पर्ड बिकॉज ऑफ द fall in RBC lifespan. Okay, hence the people who have G6PD deficiency they are protected from malaria caused by Plasmodium falciparum. So this is a little protective against malaria. Okay, so clinical disorders are hemolytic anemia because of deficiency of the enzyme, and there is connectors. Newborn में connectors हो सकता है. Okay, the triggering factors are very important. हम लोग will now see the triggering factors. Triggering factors में आता है कि the ingestion of fava beans. I'll try to move closer to the camera. Okay. Triggering factors के अंदर आ रहा है ingestion of fava beans. मतलब ये fava beans है, एक टाइप का वेजिटेबल है जो अगर जो लोग कंज्यूम करते हैं if they are deficient in G6PD they may have symptoms. Antimalarial drug like primaquine, then dapsone, sulfonamides, aspirin, nitrofurantoin, ये अलग अलग एंटीबायोटिक्स है. अगर if these are given to a person with GCP deficiency, the person will have symptoms. Okay, तो ये जो है this all these can lead to precipitating attack of GCPD deficiency. Okay, so how can you diagnose this disorder? This can be done by testing for GCPD deficiency. Okay, there can be quantitative estimation of GCPD deficiency. ये इसका जो level है can be done in the blood. अगर ये level कम है, the person is likely to have GCPD deficiency. And how this patient can be managed by avoiding oxidative stress. If anemia is severe, they may give a blood transfusion to the patient. Okay, and the hemolytic episodes can be avoided by warning patients about the drugs and the fever beans. मतलब पेशेंट को बोलना पड़ेगा कि आप ये अलग अलग जो ड्रग्स हैं और फीवर बीन से आप नहीं खा सकते, अदरवाइज यू विल अगेन गेट अटैक ऑफ hemolytic anemia. And every time before you give these drugs to a before you are giving these drugs to a patient of before you are giving these drugs to a patient of GCPD deficiency, you should of any patient should first do the testing for G6PD level. अगर वो deficiency है तो आप ये जो दवाइयाँ हैं प्राइमाक्विन, डैप्सोन, सल्फोनामाइड्स, नाइट्रोफिरेंटोइन, ये दवाई आप दे नहीं सकते इस पेशेंट को. ओके, so now we come to case of diabetes mellitus. Again, this is a very commonly asked question. Okay, अब यहाँ पे जो है there can be two different types of case studies in a patient with diabetes. Okay, यहाँ पे जो है what I'm able to see is that this is a case जहाँ पे diabetes diagnose हुआ है accidentally. और other case you may have is diabetic ketoacidosis. Okay, both of these are very commonly asked. इसलिए ये आपको आना बहुत जरूरी है दोनों केसेस में. यहाँ पे पेशेंट टाइप 2 डायबिटीज का है. ओके, व्हाट इज डिफरेंस, वी विल सी दैट. Here you have 50-year-old female on the higher side. She is there. She is having excessive thirst and hunger with increased urination. डायबिटीज के अंदर जो है ये एक कॉमन सिम्टम्स देखे जाते हैं. There may be polyphagia, polyuria and polydipsia in the patient of diabetes. Okay, this polyphagia पर्सन ज्यादा खाता है, polyuria उसको ज्यादा यूरिन पास होती है, उसको the person gets excessive thirst and there will be polydipsia. Okay, otherwise she is normal. Laboratory report, the random blood glucose is showing to be 250 mg per dl. Okay, now in the book there is a clear criteria for diagnosis of diabetes. Okay, what are the different के plasma glucose फास्टिंग में कितना होना चाहिए, पोस्ट पेंडियल 2 घंटे खाना खाने के बाद कितना होना चाहिए. All these criteria are clearly given in the book. You should know this. So this criteria shows that ये यहाँ पे 250 mg per dl. अगर blood glucose at any point is about 200 mg per dl, इसका मतलब है you can diagnose diabetes in that person. Okay, 200 के ऊपर गया ब्लड ग्लूकोज, मतलब आप बोल सकते हो कि डायबिटिक है वो पर्सन. ओके, so urine again is positive for glucose with glucose chips. Okay, this again shows that glucose level is high. There's something called as a renal threshold for glucose. अगर blood glucose level 180 mg per dl से ज्यादा होता है, then the blood glucose level, the glucose will start appearing in the urine also. मतलब यूरिन में अगर ग्लूकोज पॉजिटिव आ रहा है, मतलब ब्लड ग्लूकोज का लेवल 180 mg per dl से ऊपर जा रहा है, इट मीन द पर्सन इज लाइकली टू बी अ डायबिटिक. ओके, तो यहाँ पे अगेन इफ यू कैन सी दैट 2 टाइप्स ऑफ डायबिटीज. ओके, तो टाइप 1 टाइप 2 दो टाइप के हैं. टाइप 2 के अंदर इंसुलिन लेवल्स आर नॉर्मल और इवन हायर, बट देयर इज रेजिस्टेंस टू द एक्शन ऑफ इंसुलिन. ओके, इंसुलिन रेजिस्टेंस यहाँ पे होता है, विच इज द हॉलमार्क ऑफ टाइप 2 डायबिटीज. So characteristic clinical disorders, there is polyuria, okay, which means that there is urine output of more than 2 liters per day, because glucose is osmotically active. Okay, so because when glucose is excreted in urine, there will be water loss along with it because of osmotic diuresis. The person will have polydipsia क्योंकि ज्यादा यूरिन लॉस हो रहा है, इसके वजह से there is more requirement of water. The person will drink more water. This polyphagia, because glucose is lost, to compensate for energy requirement, person will have polyphagia. The person will also eat more. Okay, but still the person is likely to have a weight loss in spite of eating more. तो आपको ये criteria definitely पता होने चाहिए कि what are the different criteria for glucose. Random glucose कितना allowed है, fasting कितना होता है, normal level 70 to 110 mg per dl. Okay, postprandial is normal up to 140 mg per dl. एंड ग्लाइकोसूरिया मतलब ग्लूकोज इन यूरिन कभी भी प्रेजेंट नहीं होना चाहिए. अगर ग्लूकोज यूरिन सैंपल में आ रहा है, दैट पॉइंट्स टू डायग्नोसिस ऑफ डायबिटीज. ओके. Okay, तो उसके बाद में यू शुड ऑल्सो नो अबाउट द ग्लूकोज टॉलरेंस टेस्ट. ओके, इट मे नॉट बी आस्क्ड इन द केस स्टडी, लेकिन वो अलग से क्वेश्चन उसके ऊपर आ सकता है. ग्लूकोज टॉलरेंस टेस्ट कैसे करते हैं? 75 ग्राम ग्लूकोज पेशेंट को देना है. पेशेंट का सैंपल कलेक्ट करना है इन फास्टिंग स्टेट एंड पोस्ट पेंडल स्टेट. तो अगर फास्टिंग में अगर उसका सैंपल ऑलरेडी हाई है, अगर 110 के ऊपर है, पोस्ट पेंडल में अगर 200 के ऊपर जा रहा है, पर्सन इज लाइकली टू हैव डायबिटीज. HbA1c also is an important marker because HbA1c जो है वो पर्सन के डाइटरी पैटर्न पे डिपेंड नहीं करता. If HbA1c normal level is below 5.7, if it is 6.5, that itself is a diagnostic criteria for diabetes. Okay, so mainly these are the important investigations: blood glucose levels and HbA1c levels. Okay, HbA1c भी आपको पता होना चाहिए. Okay. For treatment of this disorder, ट्रीटमेंट कैसे करेंगे? तो उसमें बेसिकली देयर इज डिफरेंट ड्रग्स डिजाइन टू लोअर द ब्लड ग्लूकोज लेवल्स होते हैं, और इज कॉल्ड एज ओरल हाइपोग्लाइसेमिक ड्रग्स. along with that there is lifestyle modification. पर्सन को एक्सरसाइज करना चाहिए बिकॉज एक्सरसाइज ऑल्सो improves द ग्लूकोज टॉलरेंस. एक्सरसाइज एक्चुअली लोअर्स द इंसुलिन रेजिस्टेंस. तो इंसुलिन का जो एक्शन है बॉडी में एनहांस होता है पर्सन अगर एक्सरसाइज करता है तो. द पर्सन शुड टेक अ लो कार्बोहाइड्रेट एंड हाई फाइबर डाइट. मेनली द जो लो ग्लाइसेमिक इंडेक्स का खाना है वो पर्सन ने खाना चाहिए ताकि उसका ब्लड ग्लूकोज लेवल है जो सडनली शूट नहीं हो इस पर्सन का. और डिफरेंट कॉम्प्लिकेशंस इफ दिस इज नॉट कंट्रोल्ड. तो इसमें देयर आर थ्री मेन सिस्टम्स व्हिच आर अफेक्टेड इफ देयर इज अनकंट्रोल्ड डायबिटीज मेलिटस. ओके, तो वन इज द आई. तो आंखों के अंदर देयर कैन बी माइक्रोवेस्कुलर कॉम्प्लिकेशन लाइक देयर मे बी रेटिनल इंफार्क्ट्स. There may be macrovascular complications like coronary artery disease, atherosclerosis. This may happen. Okay, so mainly the eye, cardiovascular system, and the nerves and the kidneys. ये जो है mainly affect होते हैं. Eyes के अंदर the person may have diabetic retinopathy. mainly जो है retina जो है mainly affect होता है. And then there may be diabetic retinopathy. There may also be diabetic cataract. जो diabetes है वो cataract भी cause करता है. Okay. And the other you have peripheral nerves. तो peripheral nerves get affected, जिसके वजह से there is diabetic neuropathy. मतलब the nerves progressively over time they stop functioning. This can lead to the diabetic person developing ulcers also in the feet. diabetic foot जो है अपने अपना अलग एक ये है टॉपिक है. Kidneys may get affected. Diabetic nephropathy is common in long standing disorders. ओके. ऑल्टरनेटिवली डायबिटिक बहुत सारे जो क्रॉनिक किडनी डिजीज वाले पेशेंट्स हैं दे हैव लॉन्ग स्टैंडिंग डायबिटीज, जिसके वजह से जो है उनको डायबिटीज के वजह से उनके किडनीज खराब होते हैं. दैट इज कॉल्ड एज डायबिटिक नेफ्रोपैथी. ओके, तो इसके भी क्वेश्चन, इफ दिस क्वेश्चन कैन बी देयर मेनली कि हाउ यू ट्रीट दिस पेशेंट, व्हाट इज द डिफरेंट what we say is the different levels or how you diagnose this diabetes. Okay, and then what is the different complications if the disease is not controlled. Okay, I mean ये हुआ, that is the case of diabetes mellitus type 2. what we also have is case of diabetic ketoacidosis. Okay, अभी जो ketoacidosis है, this ये अपने आप में बीमारी नहीं है. this is a complication of uncontrolled diabetes. Okay, so diabetic ketoacidosis जो है, we look at the case study first. A 16-year-old girl coming with symptoms of deep breathing, loss of appetite, vomiting, referred to medical center. Increased thirst and frequency of urination was increased, and there is high blood glucose levels, low blood pH, as well as presence of ketone bodies in urine. Okay, now you have already done the test for abnormal urine. You do Bendix test for presence of glucose in urine, and you do the Rotheras test for presence of ketone bodies in urine. तो द केस में ऐसा भी आ सकता है कि इन द यूरिन सैंपल बेनेडिक्स टेस्ट वाज पॉजिटिव, ये भी आ सकता है. ऑल्टरनेटिवली यू में भी गिवन कि जो ग्लूकोस्टिक्स है, जो डिपस्टिक होता है वो ग्लूकोज वाला, इट शो डिपस्टिक यूरिन डिपस्टिक शोड प्रेजेंस ऑफ ग्लूकोज एंड कीटोन बॉडीज इन द यूरिन. दिस में ऑल्सो बी टोल्ड टू यू. ओके, तो ये जो है इट कैन बी प्रेजेंटेड इन डिफरेंट वेज. बट व्हाट इज इंपॉर्टेंट इज दैट यहाँ पे ब्लड ग्लूकोज लेवल हाई है इस पेशेंट का, यूरिन में अगर ग्लूकोज कीटोन बॉडीज दोनों प्रेजेंट है, मतलब दैट इज 100% द केस ऑफ डायबिटिक कीटोएसिडोसिस। ठीक है, अगर ये सेंटेंस कहीं भी आपके इसमें आता है केस स्टडी में, यूरिन टेस्टेड वाज पॉजिटिव फॉर ग्लूकोज इन कीटोन बॉडीज बाय एनी टेस्ट, बाय डिपस्टिक या फिर बाय द बेनेडिक्ट एंड रोथेरास टेस्ट, ये 100% द केस ऑफ डायबिटिक कीटोएसिडोसिस इसके अंदर होगा है। ओके, तो ये प्रोबेबल डायग्नोसिस आपको आपको पूछा जाएगा, विल बी आस्क्ड, दिस इज द केस ऑफ डायबिटिक कीटोएसिडोसिस, यू कैन से। ओके, एंड देयर इज हाई ब्लड ग्लूकोज लेवल्स and presence of ketone bodies in urine, and there will be glucose in the urine also. Okay, बायोकेमिकल बेसिस ये जो है, ये बेसिकली ये डायबिटीज का एक सीरियस कॉम्प्लिकेशन है which you see in a case of diabetes. Okay, when now what happens over here is that because of insulin deficiency, यहाँ पे दिया गया है, when there is insulin deficiency, this is more common in patients of type 1 diabetes rather than type 2 diabetes. टाइप 1 में इंसुलिन डेफिशिएंसी होने के वजह से होगा क्या कि जो दूसरे हार्मोन्स है, इंक्रीज लेवल्स ऑफ इंसुलिन काउंटरएक्टिंग हार्मोन्स लाइक कॉर्टिसोल, ग्लूकागॉन, these will lead to production of large amount of ketone bodies. Okay, because deficiency of insulin, glucose uptake जो है is reduced because GLUT4 जो channel है becomes inactive. So there is cells don't have glucose. Okay, because of which जो है टीसी साइकिल जो है वो ब्लॉक होता है, तो देयर इज एक्सेस एक्सटाइल कोए, लेकिन जो टीसी साइकिल में जो आगे एक्सटाइल कोए का मेटाबॉलिज्म होना चाहिए वो होता नहीं है, क्योंकि जो ऑक्सलो एसिटेट है वो भी इट गेट्स चैनल इनटू ग्लूकोनियोजेनेसिस, तो ऑक्सलो एसिटेट का लेवल कम होता है, एक्सटाइल कोए का लेवल ज्यादा होता है, जिसके वजह से टीसी साइकिल गेट्स हैम्पर्ड, रादर जो एक्सेस एक्सटाइल कोए है इट इज चैनल्ड इनटू द प्रोडक्शन ऑफ कीटोन बॉडीज, बिकॉज ऑफ विच कीटोन बॉडीज का जो लेवल ब्लड में बढ़ता है और फिर यूरिन में भी उसका एक्सक्रीशन होता है। ओके, देयर आर डिफरेंट प्रीडिस्पोजिंग फैक्टर्स, देयर में भी इंसुलिन जो है ट्रीटमेंट नहीं दे रहे हैं, एक्यूट इलनेस है, कोई दवाइयां है, ऑल दिस कैन एक्चुअली लीड टू प्रेसिपिटेशन ऑफ डायबिटिक कीटोएसिडोसिस। तो एक चीज यहाँ पे दिया नहीं गया है, विच इज दैट one more hint which may come in the case study is that the person is having a fruity odor in breath. Okay, पर्सन की जो सांस आ रही है उसमें से एक फ्रूटी ओडर आ रहा है, उसका रीजन ये होता है कि अगर देयर इज कीटोएसिडोसिस, तो जो एसीटोन बन रहा है बॉडी के अंदर, इट इज एक्सक्रीटेड बाय द लंग्स, एसीटोन हैज अ फ्रूटी ब्रेथ, एंड दैट फ्रूटी ब्रेथ विल टेल यू दैट पेशेंट जो है एसिड कीटोएसिडोसिस में है। ओके, so these are the different things over here. तो अगेन यहाँ पे बायोकेमिकल इन्वेस्टिगेशंस का पार्ट आता है, इसके अंदर सबसे इंपॉर्टेंट पार्ट यही है कि HbA1c भी रेज्ड होगा, इसका ब्लड प्लाज्मा ग्लूकोज लेवल रेज्ड होगा, ओके, GGT के अंदर लेवल रेज्ड होगा, ओके, ऑल दिस थिंग्स आर डन। ओके, दिस इज देयर। सिम्टम्स में आगे देख सकते हैं, देयर इज रैपिड डीप ब्रीदिंग, आल्सो कॉल्ड एज कुस्मॉल्स ब्रीदिंग, बिकॉज ऑफ द कीटोएसिडोसिस देयर इज stimulation of the respiratory system that leads to rapid deep breathing, a fruity breath in odor, and there is vomiting and confusion in this patient. ठीक है, which tests are done for ketoacidosis? ब्लड ग्लूकोज लेवल जो है डेफिनेटली होगा, इट विल बी ऑन द हायर साइड, तो ब्लड ग्लूकोज लेवल है सीइंग ऑन द हायर साइड, इट इज देयर। कीटोन बॉडीज सीरम में कोई करता नहीं है, बट इफ कीटोन बॉडीज आर प्रेजेंट इन यूरिन, दैट इटसेल्फ इज एन इंडिकेशन ऑफ diabetic ketoacidosis. Okay, in arterial blood gas analysis you see the pH is less than 7.3, नॉर्मल रेंज जो है वो होता है 7.35 to 7.45, लेकिन कीटोएसिडोसिस के अंदर द बिकॉज ऑफ द मेटाबॉलिक एसिडोसिस द आर्टिकुलर पीएच लेवल ड्रॉप्स, बाइकार्बोनेट जो है इट फॉल्स बिकॉज बाइकार्बोनेट इज यूज्ड अप फॉर द बफरिंग, bicarbonate is used for buffering of the excess acids. और there also one anion gap होता है. Okay, so when you learn about acid base balance, you will learn that when there are excess unmeasured anions in the plasma, that leads to an anion gap. Okay, so so there is a normal anion gap metabolic acidosis, and there is a high anion gap metabolic acidosis. Okay, so diabetic ketoacidosis leads to a high anion gap metabolic acidosis. As you can see over here, यहाँ पे anion gap is more than 12 milliequivalents per liter. Okay, so this is there. So how do we treat this disorder? ये भी इम्पोर्टेंट पार्ट है इसके अंदर, बिकॉज देर इज डेफिशिएंसी ऑफ इंसुलिन. तो इंसुलिन दिए बिना आप ट्रीट नहीं कर सकते. इंसुलिन हैज टू बी गिवन इंट्रावीनसली. सो इंसुलिन इज गिवन, it will lower the production of ketone bodies, it will help the glucose metabolism, and in this way the patient will improve. Okay, now many times what happens when you give insulin, the potassium है, it moves from the extracellular space into the intercellular space. तो जो पोटेशियम का लेवल है वो गिरता है सीरम के अंदर. दैट्स व्हाई यू मे हैव टू गिव पोटेशियम सप्लीमेंटेशन आल्सो टू दिस पेशेंट. तो इंसुलिन के साथ कई बार आपको पोटेशियम भी इंटरवेनेस लेना पड़ता है. बाइकार्बोनेट, अगर पीएच बहुत कम हो गया पेशेंट का तो उसको बाइकार्बोनेट देना पड़ेगा टू रेज द पीएच लेवल. ओके, तो इसमें दिया गया है व्हाई पोटेशियम सप्लीमेंटेशन इज नीडेड, बिकॉज इंसुलिन promotes the influx of potassium. It promotes the entry of potassium into the cells, एंड दिस वे तो प्लाज्मा पोटेशियम लेवल जो है अचानक कम हो सकता है. इसलिए पोटेशियम का लेवल मॉनिटर करना चाहिए, और अगर लेवल कम हुआ है उसको देना पड़ता है सीरम पोटेशियम. This is there. Now this is a case of gestational diabetes mellitus. I don't think this will be asked to you, क्योंकि ये जो है थोड़ा सा हायर साइड पे है. बट जो डायबिटिक कीटोसिस का जो केस है और दूसरा केस जो था दैट इज टाइप 2 डायबिटीज मेलिटस, दे आर वेरी कॉमनली आस्क्ड. तो आपको ये पता तो डेफिनेटली होना चाहिए. ओके, so here we have gestational diabetes mellitus. Okay, so here in ARDS we are able to see this कि premature, यहाँ पे केस स्टडी है. यहाँ पे जो मेन वर्ड है स्टार्टिंग में आ गया है, अ प्रीमेच्योर बेबी. दिस इज अ वेरी बिग हिंट. प्रीमेच्योर बेबी का जहां पे सवाल आता है वहां पे फर्स्ट थिंग विच स्ट्राइक यू इज रेस्पिरेटरी डिस्ट्रेस सिंड्रोम. ओके, सबसे पहले यही आना चाहिए. दिस इज बोर्न टू अ डायबिटिक मदर. ओके, बट जो प्रीमेच्योर बेबी है ये बहुत बड़ा हिंट है. प्रीमेच्योर जहां पे आता है वहां पे आपको तुरंत से पहले मन में आना चाहिए रेस्पिरेटरी डिस्ट्रेस सिंड्रोम. Okay. Symptoms of rapid breathing with grunting sound and the cyanosis, blue colored fingers and toes, which is basically cyanosis. X-ray chest revealed generalized opacity, and lab report confirms hypoxia and retention of carbon dioxide. Okay, as you can see यहाँ पे patient का जो lungs है proper काम नहीं कर रहा है because of hypoxia and retention of carbon dioxide, and the X-ray chest is revealing a opacity. यहाँ पे उसका X-ray दिखाई दे रहा है डिफ्यूज बायलैटरल पल्मोनरी इन्फिल्ट्रेट्स. तो यहाँ पे उसका जो नॉर्मल जिसके अंदर जो क्लियर पिक्चर आना चाहिए वो यहाँ पे दिख नहीं रहा है. ओके, जनरलाइज ओपेसिटी है इसके अंदर. ओके, तो यहाँ पे डायग्नोसिस क्या है? तो लाइक आई टोल्ड यू कि जो प्रीमेच्योर चाइल्ड है, अगर आपको ये हिंट दिया हुआ है केस के अंदर, then this is mainly a case of what is known as RDS or respiratory distress syndrome. Here it is neonatal respiratory syndrome. Okay, जो premature baby है उसमें क्या होता है कि when the baby is inside the womb, we have by biochemical basis we can see. biochemical basis में बहुत clearly दिया हुआ है. This is a very important biochemical basis. कि इसमें होता क्या है basically. Okay, what is the biochemical basis over here is that disorder is seen in babies which are born at or before 37 weeks of gestation. Normally, the बच्चा है, it becomes a term.
I need a little information to understand what you're asking. Could you please complete it?
जो बच्चा है, basically it is becomes a term child at 37 weeks of gestation. उसके पहले अगर वो born होता है, तो उसका क्या, उसको breathing में difficulty आ सकता है. This is because of a deficiency of the phospholipid. उसका नाम है डाइपैल्मिटॉइल लेसिथिन. कैन यू सी दिस? ओके, तो यहाँ पे फॉस्फोलिपिड इसका नाम है डाइपैल्मिटॉइल लेसिथिन, और ये जो है इट वर्क एज अ सर्फेक्टेंट और पल्मोनरी सर्फेक्टेंट. तो प्रीमेच्योर चाइल्ड है, this will have a high tendency to have RDS because lungs are immature and they cannot make enough surfactant. Like when if you have ever observed a plastic sheet, like if you are filing a paper in a plastic sheet, the sheets are like stuck to each other because they collapse because of the surface tension. Okay, तो जो ये है surfactant, इस surface tension को lower करता है because of which जो बच्चे का लंग जो कोलैप्स हो सकता है इन एक्सपीरेशन में। जो एक्सपीरेशन में क्या होता है, लंग के जो दोनों वॉल्स है दे कम क्लोज टू ईच अदर। ओके, तो ये जो सरफेस टेंशन को कम करता है सर्फेक्टेंट एंड प्रिवेंट्स कोलैप्स ऑफ लंग एल्वियोलाई ड्यूरिंग एक्सपीरेशन फेज ऑफ ब्रीथिंग। ओके, तो जो लंग नॉर्मल लंग फंक्शन जो है डिपेंड्स ऑन द कांस्टेंट सप्लाई ऑफ लंग सर्फेक्टेंट्स। बिकॉज न्यूबॉर्न बच्चा है और प्री मेच्योर है तो लंग में अब तक इतना सर्फेक्टेंट बना नहीं है, बिकॉज ऑफ विच देयर इज respiratory symptoms, they are blue colored lips and fingers and toes, रैपिड शैलो ब्रीदिंग हो रहा है बच्चे को क्योंकि वो उतना उसको ऑक्सीजन नहीं मिल पा रहा है। ग्रंटिंग साउंड इज बिकॉज ऑफ कोलैप्स ऑफ लंग एल्वियोलाई बिकॉज ऑफ dyspnea, and because of the distress in breathing the child is having flaring of nostrils, as we can see here I'm flaring of nostrils because of the labored and rapid breathing. Okay, now in this case to diagnose you may do a arterial blood gas analysis. Okay, so there will be respiratory acidosis. As you can see on chest x-ray, the chest x-ray, if you see over here, you see the chest x-ray over here, they are diffuse bilateral pulmonary infiltrates, मतलब pulmonary जो field है वो clear नहीं है, they are seeing many infiltrates in this case. Okay, so this is the main thing. Now one question which is important and which may be asked to you is that how can you assess the maturity of lungs बिफोर डिलीवरी। मतलब बच्चे को आरडीएस होने से पहले आपको पता लगाना है कि उसको आरडीएस होने वाला है। सो यू कैन टेक प्रिकॉशंस, यू कैन टेक प्रिकॉशंस एज सून एज चाइल्ड इज बोर्न। सो हाउ डू यू डायग्नोज आरडीएस बिफोर चाइल्ड इज बोर्न? There is something called as an LS ratio, less than sphingomyelin ratio. Okay? तो ये जो है this is done in amniotic fluid. It's very important to remember कि amniotic fluid के अंदर होता है। amniotic fluid को जो कलेक्शन किया जाता है फ्रॉम द मदर्स एब्डोमेन के थ्रू नीडल पास करके, उसे एमनियोटिक फ्लूइड के अंदर जो है एलएस रेशियो किया जाता है। okay? जब एलएस रेशियो इफ इट इज मोर देन 2 इट सजेस्ट्स दैट देयर इज एडिक्वेट फीटल लंग मैच्योरिटी। मतलब बच्चा जो बॉर्न होने वाला है उसके लंग्स मैच्योर है, दैट पर्सन चाइल्ड इज नॉट लाइकली टू हैव आरडीएस। ये एमनियोटिक फ्लूइड जो है इट गोज इनटू द बॉडी, द चाइल्ड्स नोज इनटू द लंग्स, तो उसके वजह से जो है कैन फाइंड आउट कि बच्चे के लंग्स में लेस्थिन और स्पिंगोमाइलिन का रेशियो कितना है। रेशियो 2 से ज्यादा है मींस देयर इज एडिक्वेट फीटल लंग मैच्योरिटी। ओके, एंड how you may treat this patient is this is by you may give arterial surfactant, you can give to the child in form of a bolus installation। मतलब बच्चे का क्योंकि बच्चे के लंग में surfactant नहीं है, you may give surfactant from outside and that will help the child, and then of course you have to give the child oxygen also because you have to give the child respiratory support. Okay, this is that. Now among the more common case studies I'll go through them first. Okay, so now we have a case of type 2A hyperproteinemia. Okay, this is a case of primary familial hypercholesterolemia. Again, this is a genetic disorder in which the person's uh, cholesterol level tends to be higher. तो यहाँ पे केस दिया गया है that 42-year-old male is coming with complaints of chest pain and shortness of breath. Okay, और उसके father जो elder brother है they have died because of heart attack at a younger age. Okay, this is a very strong indication. Okay, उसका जो ये है on examination there is a multiple nodular xanthomas on the elbow, fingers, ashes, tendon and buttocks. तो उसके body surface पे जो है multiple xanthomas. Glucose level is normal, but serum cholesterol level is very high. It is 430. Serum cholesterol level is 430 mg per dl. Triglycerides are normal. LDL level is very high. तो कोलेस्ट्रॉल का जो LDL पार्ट है बहुत ज्यादा रेज्ड है, HDL part is low. So this is a case of टाइप 2A हाइपरलिपोप्रोटीनेमिया. ओके, इसके अंदर बेसिकली मेन फैक्टर्स क्या है? पर्सन इज शोइंग chest pain. There is likely that the person has chest pain. There is likely the person is having atherosclerosis. Okay. Also there are multiple xanthomas जो है उसकी बॉडी के ऊपर है. Xanthoma जो होते हैं that is basically deposition of cholesterol or lipids in the skin. And there is high serum cholesterol and low triglycerol. तो जब सीरम कोलेस्ट्रॉल लेवल जब बहुत हाई होता है और जो फैमिली में भी हिस्ट्री है हार्ट हार्ट अटैक की, दिस इज लाइकली टू बी अ केस ऑफ टाइप 2A. हाइपर कोलेस्ट्रोलेमिया है, हाइपरलिपिडेमियाज है, इनके मल्टीपल टाइप्स है, पर जो टाइप 2 है सबसे ज्यादा कॉमन है. ओके. और टाइप 2A का रीजन ये है कि देयर इज अ डिफेक्ट इन द रिसेप्टर फॉर द LDL इन द लिवर. अगर लीवर में LDL रिसेप्टर डिफेक्टिव है, देन देयर इज अ चांस कि जो ब्लड में कोलेस्ट्रॉल है उसको क्लियर नहीं हो पा रहा है, and because of this there is a raised level of serum cholesterol and serum LDL in the blood. Okay, so इसकी वजह से क्या होता है? Because of this high level of LDL cholesterol, which is the bad cholesterol, there is premature coronary atherosclerosis in type 2 hyperlipidemia. इसकी वजह से पेशेंट को चेस्ट पेन होता है because there is a formation of atheroma in the cardiac artery. Xanthoma of tendon, अगर टेंडन के अंदर xanthoma है, it means xanthoma का मतलब है deposition of the cholesterol in the tendon which leads to formation of a yellow nodule. तो these are nodular swellings formed by deposition of LDL derived cholesterol in the tissue macrophages. तो लिपिड ड्रॉपलेट्स जो है ये जमा होते हैं. अगर टेंडन के अंदर हो रहा है, that is likely to be a tendon xanthoma in type 2A. या फिर ट्राइग्लिसराइड नॉर्मल है लेकिन LDL लेवल जो है ज्यादा है. ओके. So advice to give this patient, you can give this patient a low cholesterol diet and low saturated fat diet. Okay. And to lower the person's cholesterol level, you can give the patient HMG co-reductase inhibitor. अब जो बॉडी में जो कोलेस्ट्रॉल सिंथेसिस होता है उसके अंदर मेन एंजाइम इज द HMG co-reductase enzyme. उसके अंदर you have to give this drug called statin, which will lower the cholesterol level, and this way there will be a lower level of LDL cholesterol, and this way the person's cholesterol level can be lowered and symptoms can be improved. Okay, fine. So I have completed case studies on carbohydrate and lipid metabolism. Okay, just a minute, I'll just change this.